Okay, it's 10 o'clock. Colleagues, shall we start? Is everybody who needs to be, so if I can just check with our external people on the call, Tan and Andy and people like that, can you hear us okay?
Yes, I can hear you.
Lovely. Could you just turn that up a bit, the volume in the room, please? So I can hear. Okay, so welcome everyone to our Integrated Care Board meeting held in public. There are a few welcomes that I need to make in addition to the normal ones, and I'll get to some of the apologies in a second. So in the room we have a new colleague, Nick. Welcome. Nick is going to be the pharmacy attendee. Nick, just a couple of minutes on yourself, please.
Yeah, thank you. So my name is Nick Kay. I'm a community pharmacist by background. I've had businesses in Newquay. I currently have businesses in Penryn. Other roles I've done is I have been a partner in general practice. I left about 16, 17 months ago. Currently, I am the CEO of Community Pharmacy Cornwall, which represents all community pharmacists in Cornwall. And a declaration of interest, I'm also chair of the National Pharmacy Association, which represents all independent community pharmacy across all 4 nations. I'm really pleased that you've invited us to come, Chair. Thank you.
Thank you. We are in the process of inviting John Eva for optometry sector, and also Jenna Murgatroyd from the dental representative sector. So they'll be with us probably from next month. Good form also. Just want to welcome Kelvin. Kelvin is one of our new board participants. You are Chief Information Officer and System Lead for the Integrated Care Board. So welcome. Many day jobs by the sound of it. So good luck to you. And also congratulations formally to Patrick, who is now our Chief People Officer. So well done to you. I don't think there's anybody I've missed. No. In terms of apologies, we have a number: Carol, Ali, Margaret, Caroline, and Mary, I think, may be on the call, who's got COVID. So if she is, a huge thanks to Mary from your home. So I hope you're feeling okay. And then we've got Neil, who's got some personal issues as well today. So I hope, unless there's anybody else I've missed. Neil, you're online. Thank you. You're an absolute star. So let's move on to the minutes. Let's go first of all to the 14th of September. Sets of minutes. Are you happy for me to record those as accurate? Any changes? No? Okay. Thank you very much. We'll take those as approved. Then there's the extraordinary ICB board meeting that we held on the 28th of September to do with the medium-term financial plan that had to be shared with the region by the end of the month. So are you happy with those minutes? Yeah, all good. Thank you very much. So I think the health and care vignettes is the next item on the agenda. If I could just ask Lucy, from your perspective, a number again, which ones would you like us to talk through in any particular order?
I think the loss with your dental surgery pilot is a really successful, and it's mentioned in many of your papers that are in today's pack, so I won't go into that too much, but just to say that we've had a lot of national interest in this, so it'd be really interesting to watch and learn, and we'll be covering and documenting working with the dental surgery just to sort of really capture what we could do and how this might go further. So we'll keep people at the board updated on that. Given that it's Cancer Awareness Month this month, we've really sort of focused on the support available for women impacted by cancer, and this includes a series of films which show not only a free dance session that's supporting women that runs in Newquay, but also across Cornwall, but also the personal stories from Maz, Joe and Sally, who talk about very openly their experience from diagnosis right through to treatment and afterwards, and it really shows this importance of both the medical response but also that wider support from community and for friends as well. And then we hear from Karen and Doreen, who's a full-time carer to her mum. When I met with Karen, we just couldn't stop talking, so I've included the short version and the longer version, but again it just really shows the importance of the important role that carers make in our community, the unsung heroes often across our communities, but also again how important that support is. I met Karen and Doreen at a Singing Happy dementia group, but also at a carers cafe, so they really did utilise what support is available locally. Thank you.
Any points or observations about the video vignettes? No? Yes, Steve.
As ever, all three were fantastic, but the dental surgery pilot particularly, John, I just want to acknowledge the work behind that. One of the issues that we've discussed at an integrated care board previously is the challenges around access to dental services, and that seemed a hugely challenging thing to be tackled, and it's really positive to see progress being made in this area, and I think it's got huge potential to be rolled out.
Andrew?
Yeah, just seconding what Steve said and reading the Lost Withiel example, really, the lesson I was wondering is how replicable is this and scalable is this? Because I think when this originally came through my committee, it was a question of using this as a pilot for further expansion, because I think it's obviously a county-wide problem, countrywide problem that we can learn from.
Yes, Kate?
I think one of the things that we need to make sure that we do if we're looking to roll out the Lost Withiel model elsewhere is to be really clear around the funding formula for dentistry. So it only covers 50% of the population. So our role as commissioners is to make sure that it covers the 50% of the population who'll get the maximum benefit from accessing NHS dentistry. So I think there was a piece of work, Lucy, around the communications to support the Lost Withiel pilot and the replication of it elsewhere.
Okay, any other points? Debbie?
Can I speak to the dementia vignette, please, if colleagues have finished commenting on the dental one. So it was a very poignant story, wasn't it? You know, hearing from carers in that situation was, I listened to it twice, so please thank the daughter who spoke so candidly about her experience. And on Tuesday it was World Mental Health Day, so I think it's important to sort of draw the connections across that. You know, we want to ensure that all of our services are supporting people living with whatever condition it is, in this case dementia, but also their carers are supported. And part of that is the work that we're doing jointly between primary care and our older adult mental health services and the third sector to really improve the offer to people who are living with dementia. And I'm delighted to say our dementia diagnosis rates have improved over the last year. So if you think of the successes of the joint working, we've gone from 53% dementia diagnosis rates as a system in 2021 to 58% in 2023. And the reason why that's so important isn't because of the label, but it is about the earlier access to support for not only the individual living with dementia, but also their family and loved ones. So just wanted to use that hook really, John. Thank you.
Excellent. Okay. So, Lucy, maybe for next time, as we've got some new colleagues around the table, I'm just wondering whether, Nick, we might be able to think about doing some vignettes, maybe from the pharmacy. We've got dentistry we've just done, maybe from optometry as well. There's something about understanding these areas, and if that's okay with you, to try and
Of course, happy to.
get kind
Yeah,
of feedback.
no pressure.
So, Nick, just from your perspective, just so you know, this is bringing the patient view and citizen view right in here. And some of these things are then being used to scale up. So we'll talk later on about the Brazilian model and things like that are being used. So it's not just a nice to know. It's how do these things, which ones should we leverage and invest in and that kind of thing. All right, shall we move on? So in my desire to want to get to that, I jumped across declarations of interest, for which I apologise. So is there any declarations of interest that anyone wants to declare? Kelvin?
John, I think we just need to formally record, obviously, my other roles.
We'll take that as read for every time. Thank you. Another? Okay, thank you. On the matters arising, I'd like to deal with all of those, which I've skipped over those as we go through the agenda, if that's okay. Okay, so we'll move on from the vignettes, if that's okay with everyone. Yeah. But excellent work again. We did say we were going to actually do a bit of a sweep up of all the previous ones to see which ones are being taken forward.
I was going to wait until forward plan, but my understanding we were working to a November board for that paper, if that's suitable on the agenda.
No, that's okay. Good challenge. Okay, so we'll move on to my chair's update. Now, I don't normally go through. I'm not going to bore you for 15 minutes about my chair's report, but I do want to pick out a few bits because we are at a bit of a change moment as a board. Not only we've sort of invited some other colleagues and we've changed our top team in terms of inclusion from other areas, but I just wanted to go through and celebrate some of the things that have happened and then some of the challenges that we've got. So I just wanted to thank everyone for the AGM. I thought that went particularly well to have had 100+ people, citizens, partners, etc. And where are you, Simon? With a challenge to, could you make it an entertaining finance presentation? I just wanted to say it publicly. 5 stars, well done. The only person who can make accounts sound interesting. So thank you so much for that. We had a national visit from our NHSE colleagues, and it was wonderful to get their perspective on hearing from most of our colleagues around this table, but Emma and the third sector colleagues that joined you. I just wanted to reach out and say thank you. I think we are, as Cornwall the Isles Facility, in the vanguard of actually looking positively at how we do things with the third sector. I think Steve Russell and his colleagues, Matt and Adam, that came down, were very impressed by what was going on there. I think we have to work out quite how we continue that and scale that. So I just wanted to celebrate that moment. And also recognising the fact that I'll jump from the Steve meeting to the survey results, because he commented on the perception of collaboration that he'd had before he came down was nothing like what he experienced. He experienced real collaboration between us, genuine partnership working going on. And that wasn't just for the day. It really is clear that we've come on a journey. That would be easy to make as an anecdote, so I just wanted to share with you. I saw last night, and we're going to write this up properly, I saw the full final results from our self-assessment. I hope you'll be as delighted as I am with those results. You can't please everybody all the time. That's one of the things I'll say up front. We're not perfect, we know that, and if we were, I don't think we'd have done a true self-assessment. But it is unquestionably demonstrating what you all feel, because 25 now out of the 27 of us actually responded on that. So thank you for doing that. And to have had such a positive response about the collaboration and the partnership working going on in Cornwall and the Isles Facility. For those detractors outside who don't think we are, we clearly are making huge progress. So I just wanted to register that, so thank you. I talked about the extraordinary board meeting, that was important. I also wanted to share, because it's going to be used as the day goes on, not only are we reframing the board agendas, so today is about in year. So I'm going to say this a number of times as the day goes on. I was trying to think of analogies. It's probably a poor one this morning I was thinking of, but imagine a bowling alley. I always get asked, do you want to have those little rails up on the side come up? Because I'm not particularly good at it, although I think I am. Just imagine those rails today are going to be put up primarily by me to say, those who want to stray into strategic stuff, please park it. This is about in year, this particular meeting. So please stay, if you can, within those boundaries, because next month we're going to have a board meeting on strategy and the joint forward plan and the integrated care strategy going forward. And the rotation is then going to be in year, strategic, in year and strategic. And as to be faithful to that, we are in the process of not only conducting and now finishing the survey results and the reviews of our board and what our external stakeholders feel, because we did that survey as well, Nick, just so you might not be aware of that. But also the committee chairs of the ICB have done reviews of their own committees and their performance. And that will become relevant as we get into the part 1 discussion about things like the integrated performance report, because there's something now about our committees being focused on when it needs to be in terms of in-year and then strategic. So their agendas are going to be realigned based on our strategic risks and our in-year risks more than they have before. They have been, but they need to be more before. And they'll be scrutinising more the plans that need to be in place, because there's no point actually saying, here's where we are year to date, and we hope we're going to get somewhere. We need to ensure we have the granular plans in place for our committees now to get into much more granular detail to ensure we achieve what we say we're going to do when we say we're going to do it. So I'm going to repeat that message, I'm afraid, on a number of times, because we're being joined as the day goes on. I think this shows how we're maturing. I want to reach out to both the chairs and the chief execs of RCHT and CFT. We're being joined as the day goes on by some of our colleagues who are non-execs and executives as well, that I think also demonstrates the true degree of partnership maturity that we've reached, that we can get to that point. But today's all going to be about in-year performance, in-year achievement of quality and performance and budget. To that end, just so you're clear also, Neil, who's on the call, I believe, will from today be chairing our quality committee for the ICB and resetting the new terms of reference with the colleagues on that. And Carol, while she is still with us until hopefully the end of the year, will be chairing the PCC committee, and we'll be going to advert pretty soon for a replacement non-exec for our primary CCC committee. I mentioned, Nick, earlier on the Brazilian model. We probably call it community support workers here. But again, it's an example that came out of the vignettes, where it was an idea from our place ICAs that came through the vignettes that actually caught the imagination of everybody, that is third sector based, that can support communities, and we're scaling. And I think we just need to celebrate the fact that we've put resource now, significant step up resource, driven by Kate as a result of that, into this space. So, and of course, we touched on the loss with your pilot for the dental thing. So, like I said, I wouldn't normally go into that, but I think there's a lot there to celebrate, recognise, and we are in change phase. So today and next month might feel slightly awkward for some of us because we want to talk about other things, but the agenda in our bowling alley lane is in year. So that's my summary. Thank you. Can I introduce Kate on the Chief Executive?
Thank you, John. So some of our reports overlap, so I won't go into the overlapping pieces. Winter planning's on the agenda, and we will no doubt come back to that several times over the course of the day. I just want to bring people's attention to the Integrated Care Partnership meeting in public. So the recording of the meeting can be found on the ICP website, and it's fair to say that we're moving into our outcomes phase for the ICP as well, around how we'll be holding ourselves to account for joint working across a broader public sector. I went to a meeting with the Integrated Care Board Chief Execs and the NHS England Executive Group, and while what we talked about in that meeting was really important around social care prevention and inequalities, the next meeting is going to be focusing on a paradigm shift around frailty. So all of our services across all of the country are struggling with the same issues. So the word transformation sort of doesn't feel big enough for the things that we need to do to make a shift. So that will be the focus of our meeting in November. The Women's Health Hub, we've had our first meeting that our council colleagues kindly pulled together for us with interested parties across the whole of Cornwall and the Isles of Scilly. Susan and her team will be picking that work up and moving it forward, and it will be our segue into setting up expert reference groups. So we've got a number of women who've got an awful lot of views around how their health needs should be met, and also our clinical reference groups, so that we're pulling on the broad cadre of practitioner and clinical expertise across Cornwall and the Isles of Scilly. Really exciting. And the segue from that to a meeting I had with Claire Murdoch earlier this week, all mental health leads were pulled together across the country, is around how we mainstream mental health issues beyond statutory mental health services. And I think when I worked in liaison psychiatry, 40% of people in a general hospital were there because of their presenting psychological issues, not their physical state. So I don't know what the research is at the minute around that, but for our women's health hubs, we need to make sure that health, well-being, mental illness and physical illness are all part of the work that we're doing through those hubs. What else do I want to talk to you about? So our ICB redesign is phase one. The consultation has finished and we're moving into the implementation of phase one. We are starting the pulling together of the detailed consultation document for phase two, and by the time we next meet in November, we hope to have gone live on our consultation. We've got a lot of very worried people working with us because change is horrible. The people promise that set up the integrated care boards meant that the reshaping of how we work as an ICB has taken 3 years to get to this point. So we've got lots of people who are very anxious for us to affect an outcome as quickly as possible. So that's what we're intending to do. Patrick and his team and all everybody's line managers are being supportive, but we have to acknowledge that people will still be anxious. Steve Russell, Matt Nelligan and Adam Doyle did come and visit us, and they did go away saying, oh my God, we didn't expect Cornwall to be this great, which I didn't know whether to take as a backhanded compliment or a reflection that we do hide our light under a bushel. So Steve Russell's at an HSJ summit today, and he's asked for bullet points to talk about our third sector offer. He was completely blown away by how our third sector is fully integrated into the work of public sector in Cornwall, not just the Integrated Care Board. And Rachel, I think the work your team has been doing with the third sector over many years is the bedrock for that. So we have to acknowledge the ICB hasn't invented it, but we are going to make sure we make the most of it.
Thank you,
So
Rachel.
Steve will be presenting that this morning. We've had the outcome of our Integrated Care Board annual assessment. I've put my glasses on so I don't miss any of this. So the ICB remains in a good position with regards to system leadership. So the outcome of our survey that colleagues filled in is reflected through NHS England's view of us as a system. Our preventative programmes and approaches to workforce and primary care access are all rolling out in a way that NHS England are happy with. And they're pleased that we delivered our revenue position and our efficiency plan. However, they want to see stepped progress this year around mental health access, urgent and emergency care and elective waiting times. And I think for our discussions as a board, they reflect the things that we are the most concerned about. So we all know that external assessments are a great form of governance. So if we're addressing the issues that our external assessors are finding, then we are probably looking in the right places. And then finally, it just comes back to the it's not in my report, but when Lucy was talking about the vignettes, we've got a meeting with Hazel and Jane, the mothers of Ben and Darren, on the 2nd of November, where we'll be screening the video that they brought here for us to see as a board. And part of what they're asking us for is, now what? So what? So as part of the outcome of that meeting, we will be looking for the structured programmes that we'll be taking forward that mean that families in Cornwall and the Isles of Scilly, regardless of what's wrong with their loved ones, know that they'll be listened to. And I think a lot of the vignettes that we've heard, they reflect back to us. People we work with are only human beings, and sometimes human beings get it wrong. So how can we support people to be as great as they can be for the people we serve? So we'll bring an update back from the meeting with Hazel and Jane on the 2nd of November. And then we might want to take some time to consider structurally how we fit the pieces of work into the work of everybody around this board table, not just some agencies. And that's it. Thank you.
Any questions for Kate? Debbie?
Can I just encourage everyone on the Integrated Care Board to take up the offer of the Oliver McGowan training? It's actually really, really powerful. I've done the online training, but the resources are absolutely extraordinary. You do need to set aside 2 hours to do it so that you can listen to the different injects and vignettes that come from people with lived experience. But the learning's very powerful. Alongside it, there is a really helpful handbook. And I'm wondering whether after this meeting we could just send the link out to everyone, because the intention is that everybody participates in the Oliver McGowan training, whether you're in primary care, secondary care, tertiary care, BCSE. So I would like to use the opportunity to promote that, and I think that is an action that we could hold ourselves to account on between now and the end of the year, that would be something we can report back to Hazel and Jane.
Very happy to do it. Yep.
So I think it chimes with an ask we've had from Kim Hagar around the women's health hubs. So if we plan for our mainstream services to meet the needs of our most vulnerable or most excluded people, then we are more likely to get a great solution for them, and everybody else. And I think the Oliver McGowan training, because it's not just about people with certain conditions, it's how we as people interface with other people. So I think it's a really good thing to mention, Debbie. Thank you.
All right.
And Debbie, if you'd like to send the link to me, I'll make sure it's distributed around, okay?
Yes, great. Thank you. Will do.
Any other questions? Mary?
Can I just flag up that the independent sector of 16,000 workforce also needs to do the Oliver McGowan training, and it's a lot of time and it's unresourced, just to say providers are struggling to get people through it.
So one of the issues around things like this is its core, isn't it? So if Kim O'Keefe was here, she'd be talking about the fundamentals of care. And there's something around the Oliver McGowan training, it's the fundamentals of care. Because if we don't know how we relate to others and we don't know what we look like on the other side of a conversation, care won't be great. So I would, from a statutory perspective, I'd just look at Steve and Debbie and just expect that they'd do it, and they'd have the same issue around releasing people from care. And from a third sector, I'd almost be expecting you to push us to say, why aren't you saying everybody should be doing it? So I think it is difficult, but it is a really fundamental, important part of great care delivery.
Okay. Rachel.
Just to comment on an event in the last since the last board that I think is significant for health, which is the Smoke Free for Futures Generations around tobacco control. So the announcement, and it's a command paper which I know has been influenced by Chris Whitty, and the evidence about smoking being the biggest cause of morbidity and early death. So I think I wanted to recognise it's a really important opportunity for that legislation to go through the due process, which would increase the age where people could buy tobacco products like in New Zealand, but also some investment that's been committed to a system to support smoking cessation for people who do smoke and the appropriate use of vaping for adults. So really interesting sort of bit of legislation that we'll be working together to implement, hopefully, when it comes forward.
Is that training available to lay people?
Yeah, we can put the link on our website, and we can do comms across Cornwall around training.
I see someone's put that into the chat, so if we could sort that as well, I'd be very grateful. Thank you. Okay, excuse me, I've got a tickly cough today. It's not COVID.
See,
No. I'm sitting very close to you.
No, that's all right. Tested yesterday as a family for another. Okay, so let's move on to the integrated performance report. So just sort of setting the scene a little bit here before Kate comes in here. One of the things that came out of the survey from all of you was we need to move on in terms of evaluation being empirically focused, evidence-based, and in a structured way. So I think there's something here about the movement of the year to date that I think Kate will walk us through. But there is a new set of recommendations that I just want to say to you. So for those of you who haven't caught up on admin control, we will be going through a little bit more focus on the forward-looking stuff, but we'll get to that in a second. So if you want to introduce the IPR, and then we'll go through the new format and the recommendations at the end.
Okay, thank you. So first of all, just a quick introduction to the new style format that you've got there. You'll have seen, particularly in the operational performance section, there is a focus on SPC graphs, so we can absolutely be tracking where we've been, but also to be able to identify any impacts, positive impacts of things that we've done to improve. Not all the trajectories are there by any means, and some of that, for example, with urgent emergency cares, because we're still working up that trajectory of improvement through the winter, but we'll hear more about that this afternoon under the winter item. We've split every section up, so there is the sort of summary, so what is the data telling us, but then what are our actions, and that is intended to be a forward look in there, so we need to improve on that to make that much more pointed and focused where we need to be getting to. And then there's an assurance section in that as well. Some elements are still clearly being developed, so for example in the SOF segmentation dashboard, it's only the operational data that's in there at the moment, so we haven't got the workforce data or the finance data in there. Under operational performance, children and young people data, it is still missing, and the next iteration of this, you will see the trajectories and the timelines stretching out to the end of in-year. It's not actually possible to put those on an SPC chart, so we're actually just working that through how that will look for the future. And then the rest of the graphs in the other sections will be SPC'd. We're still waiting for the health inequalities section to be finalised, and Patrick will no doubt talk about getting the metrics right. So for all of these, the focus, I absolutely agree, is about looking forward, a trajectory or a forecast of where each of those metrics is going to the year end, so we can take actions. So it's not perfect yet by any means, but hopefully it is a good start, and I'd welcome any further feedback on it so that we can really get this right for future iterations. Under operational performance, that the couple of areas I was just going to flag was the urgent emergency care. But as I say, we will hear more about that this afternoon under the winter plan, to go into that in more detail. And the other one was elective care, and that's particularly around the risk to the 65-week delivery at the end of March 24. But again, we're going to hear more about that this afternoon, so I won't go into detail on that at the moment. So I'm now going to hand over to Susan for the quality section, and then she'll hand to Patrick and Simon for their sections.
Thank you, Chair. So in the quality section, I think the comments back that we need to refine throughout the IPR is that quality, we have our statutory functions around quality when it comes to infection control, our safety elements, and safeguarding, which is within the report. However, there are other issues that wrap around our urgent and emergency care pathways plus our planned care pathways. And a lot of the work that we've been doing since the last board meeting is how we refine collectively, both Chris and I, the mortality and morbidity and how we measure that going forward. Because some of the work that we've done through the System Coordination Centre, particularly as we're moving into winter, and we know that we had excess deaths last year during our winter periods, is how do we track that, Chair? How do we, what are our injects to mitigate some of that harm that's coming our way? And we know that we get harm. We've got rising COVID. It goes in peaks and troughs. We've seen a peak in respiratory syncytial virus, which is what we tend to see in children, flu and noro. So we've done some winter preparedness around our infection control, which is one of our statutory functions, to get us into a better place. What we need to do, as Kate's just said, is how we plot the trajectories that reduce the harm and therefore reduce our mortality and morbidity. So we've done quite a lot of work, and that's what I really wanted to bring out from our quality section in partnership with Chris here. We've done some more work around our learning from deaths, particularly in our disability mortality review. Getting a skill set to do those reviews has been difficult, and going through the redesign, we have brought in 3 people on 0-hour contracts just to get us through the redesign, come out the other end, but continue that work going, because it's incredibly important. I think I'm not going to say anything more on our IPAC, our infection control, because as that work will be an iterative process as we go through the winter, tracking it and setting those targets to reduce it. I don't know at this point. We will be talking about the winter plan, and particularly the harm that we're seeing through ED crowding, ambulance handovers, and our category 2 mean time, which we know hits our patients that have strokes, fractured neck of femurs, and we know they were some of our drivers last year around excess mortality. So doing more work around those areas particularly, and again setting those trajectories, are vital for this winter's work. Chris, is there anything you want to add?
I'll just emphasise really the mortality data really is really important. That is, we see that there was 644 excess deaths. So that's what we that's higher than the expected for last year, of which 203 of them were in December. And it's just to reiterate, that shows us the pressure we have under winter and flow, and I think that's what we have to hold ourselves to account for. And we'll talk more about that in our mortality and morbidity system group meeting in part 2. That's to me says it in numbers. That's what we have to avoid as a system.
Okay, let's get through everyone's summary and then we'll open up to questions. So Patrick.
Thank you, Chair. So page 43 of the pack, following on from Kate's intro, this is definitely work in progress relating to workforce data at system level. But the table in that page gives an indication of the kind of data that we are looking to be able to populate into the IPR. So the intention is that we would start with some of the system oversight framework data that relates to workforce, and be reporting aggregate data at this level into that dashboard. That would be balanced off with equalities data and things like staff survey data that give us a bit of a richer picture, but founded in kind of core establishment information. The other part that we would want to be doing over time is, as the workforce efficiency programs are embedded, then this becomes a way of keeping track of performance and delivery against those. And then the whole system aspiration, you'll see that there's reference to primary care data, and I'd like to be able to paint a picture of the total health and care workforce over time, so that this board and the ICB's workforce committee can see that at a glance. So our issue at the moment is around making sure everyone is comfortable with the data sharing and the infrastructure, the digital infrastructure to be able to populate this as a real-time dashboard. But as the page before makes comment, we're working on that, and Deloitte are helping us with some of that mapping at the moment as well. So work in progress, but an indication of what we want to come.
Thank you. Simon?
Comment, because obviously the workforce financial impact is significant over the last few years for our system, and we see within the finance position year to date, the agency numbers continue to be a huge financial pressure on our organisation, so understanding those numbers will be key going forward.
Okay, so we've got a bit of time to talk about the new format and each individual area. So let's just deal with this in some sort of structured order. What do you, taking the point, and maybe we'll leave this to a moment, in a moment, about forward trajectories and the detail and the how, but what do you think about the current format? You happy with it as a reporting mechanism? Yeah, I see nodding. Yeah, Rachel?
I think just a comment about format is that the data that's included are varying quite a lot in terms of whether they're showing a current position, whether they're showing a benchmark, whether they're showing a direction of travel. And I think for people who are reading it at board level, is having something very consistent so that we're knowing what we're looking for in it. And I know that certain data can't always be shown in that way, but where that can be the same colour or the same format for each of them, I think would really help us to have that view at this high level. And I think the narrative bit that was introduced at the beginning, you know, with the key points, it's not just the numbers, it's someone having some analysis to give you a way in. From that, you know, I picked out about the orthopedic being one of the reasons for delays for elective care, which looking at all the dashboard, that would have been hidden, and it was right there. And so that type of analysis, I think, is really helpful for us to start with.
Okay, well said. Steve?
Yes, but I think the content is very NHS focused, and within that it's very much predominantly CFT and RCHT reporting, and clearly that's a really important part of our system. Patrick talked about the intention for the workforce reporting to be system wide, and talked about care workforce and other aspects. So I think my question, and I'm not sure if it's a content question or not, but my question is, do we anticipate a financial quality and safety performance in a workforce dashboard that shows the entirety of the health and care system? And in which case, if that is intended, how do we get to that point? Or is it the intention, and it may be appropriate that we focus more predominantly on the NHS aspects, as is the current reporting set?
So I think we definitely need to do the former and work towards the latter and work towards the former. So the slide that Patrick's put in around where the workforce distribution, it is very NHS focused, even with general practice in there. So I think we should just be able to reflect that, shouldn't we? So that we should just be able to fill that in. Whereas when we start looking at our third sector growth by type of alliance across Cornwall and the Isles of Scilly, I think that will take us longer to get to. But for a value for money evaluation, when we know that we should be getting, 4 times more value out of third sector spend than statutory spend, it's a great way that we could over time start looking at our channel shift intentions and whether we're getting what we thought we were going to get. My other point was just about benchmarks. So while I've got the mic, we have to have a benchmark that everything triangulates back to. We can't take benchmarks from different times. So if 1920 is the money and 1920 is the activity, 1920 has to be the workforce, so that we can do like for like comparison, and we can do that across all sectors, but I think it'll take us a bit longer to get there.
Okay, on the screen, Tan.
Yeah, thanks, John. Steve, absolutely take your point, and I think that we will be helped in that space by the redesign of the committee structure, so that we have a more NHS-focused part of the meeting, and then have a wider system part. Obviously, we need to have our metrics where we are held our feet to the fire in terms of our agency spend from the soft letters that we've had, and we know that we need to measure that across the NHS, but there's also the wider system development aspects that we need to look at in terms of our whole workforce and how each part impacts on each other. So as I say, the new committee structure will help us towards that endeavour.
Debbie?
Yes, a couple of things. So looking at the the workforce slide on page 73, there's a reference to after social care, total mental health workforce staff in post. And I just wanted to test out what was the intention of that, because it depends on how you, so Emma and I, our services talk regularly about people working in mental health. Kate's already pointed out that there are lots of people involved in delivering elements of mental health and well-being, and that's different to mental health workforce in post. I think the other point to make on that is that one of the metrics that we will be held to account for as a system are the number of people with a learning disability in paid employment, the number of people with a serious mental illness in paid employment, and we know we're not doing well on that at the moment. So I'm wondering whether that was what was meant there, but it certainly is something that we should be measuring ourselves on.
My understanding of that, I think that comes from the SOF framework, and it is purely the NHS proportion of the mental health workforce. It's a specific requirement rather than the broader one. But I absolutely take the point about that ties in with the aspiration would be how can we get a fuller picture. I would want to double check the definition of that, but I think that's my understanding. Yeah, I think that bit we need to clarify and make sure.
Take that away and clarify that. Okay, Nick?
Could I just, sorry, could I just come back on that? So the supplementary to that is to absolutely agree with Kate about benchmarking. We need to take a number at a moment in time, an agreed date and an agreed number then, and an agreed date and number now, and then we need to account for the direction of travel and then identify where there's unwarranted variation, and then what are we going to do about it? There are some things that currently we're not capturing, like the channel shift. So for example, Public Health Commission VCSE, the ICB commission VCSE, we commission VCSE. So there's something about how do we ensure that we look at our integrated offer around VCSE, and because I think we might be actually doing better than we tell the story of in terms of some of that integrated delivery.
Is it on that point, Kate?
Yeah, it is on that point. Oh, my
comes on.
microphone comes on magically. So I've emailed Matt Nelligan this morning. So he's the director of ICB development, because we would like a structured way through which we engage with the VCSE for longer term contracts, with the heavy lifting not necessarily being done by the NHS. So I'm hoping Matt will come back to me and we'll look at how we set that up moving forward, which allows us to look at total spend in total budget areas, and then how we can be effective.
I don't want to come back on this, but Nick and Rachel, is it on this particular point? I've got different points.
Just on the question you've asked.
Right, you want to answer?
I just wanted to pick up Debbie's wider point as well about, for instance, measuring people in employment with a learning disability or other metrics. I'm thinking of care covenant. The NHS care covenant would be an interesting thing to measure about care leavers in the workforce. Armed forces covenant. So I think over time there will be scope for us to be thinking about what would be the interesting stuff that we want to see over and above the more mandatory requirements.
Okay. Did you want to comment, Emma?
It was a general comment.
Oh, okay. We'll come back. So let's move on to Nick.
Yeah, thank you, Chair. So I think a couple of things you asked. So for me, for the first time seeing this, the format seems usable, accessible, and I can almost understand it, even though there's a volume of data in there. So I think that's absolutely fine. I think just a couple of comments pharmacy-wise. So obviously workforce, no community pharmacy cited in there. There is a national workforce survey that's done and being done now. So I think if we connect with Patrick and share that, it will have breakdown details to us. I think that's important. I think the other thing I would say on workforce is I don't know where training fits within that, but I'm worried that, you know, even though I'm not representing general practice is going to come under a huge issue with training. We've got a new school of pharmacy opening in Plymouth. There's going to be requirements for independent prescriber training for lots of other professions. So as a system, we're going to have to be asked to step up and play to train the workforce of the future. And I don't know where that sits or where that looks like. So that's my ignorance, Chair, but it's absolutely should be flagged within that if we're a truly inclusive system. And the second point is data. Page 31 says an increase in community pharmacy completed consultations, which is great. I think it's right to flag there's a national data metric on that, which NHS England provides, but also the ICB provides commissions a unique service in Cornwall and the Isles of Scilly, which is nationally recognised, where we have weekly data of the 15,500 appointments that have been completed in 20 months. And I think we'd be remiss not to share that data set with the board, which we'd be happy to do. So I just think it's a good news story. And then cancer pilot referrals.
Just before you move on, can you catch up with Kate Maynard then
of
at the
course.
back of that? Because
no
Kate's
problem.
the sort of ringmaster on that.
Yeah, and again, ringing good news stories, although there's not been many yet, cancer referrals are in there. Again, Cornwall is the first system in the country whereby cancer referrals are happening in the west of the county, direct from community pharmacy into RCHT. So I think that needs to be recognised as a national first as well. So I think there's just some metrics within there, Chair, that I think are helpful to capture, which we'll be happy to provide. Thank you.
Thank you very much indeed. Rachel.
Yeah, thank you. Just a couple of points to me. So one, I think I recall the conversation that we had well over a year ago about having one version of information and being able to share and have that conversation. So it's really positive to see that that's coming together and, as you say, is accessible. I suppose the danger now is that this is going to grow like Topsy, and you're going to have about 300 pages of information that everybody wants because it's interesting and it's good to have an observation. My concern would be that, one, this information should reflect what the objectives of the ICB are, and that there will be a whole plethora of detailed data underneath which reflects individual positions, organisational positions, and everybody else priorities, but the board need to be cited on what the board's priorities are, and the performance report needs to reflect that. It might be, Kate, that you could then signpost or do links to detailed reports, of which I know there are on pharmacy, there are detailed workforce reports, there are, there's benchmarking data on mental health, there's lots out there. But it could be that there are, if people want to go into that deeper detail, or there's an interesting topic that people can signpost. And then I suppose particularly the workforce metrics, there's quite a lot about inputs. You can measure how many people, but if you don't see the change that you want to affect, and your point about outcomes, Kate, you're going to have a lot of inputs and lose sight of the change and the narrative that you have as an ICB. And then maybe that's about the evolution to an outcome approach, but just be cautious about having a lot of inputs. And again, those are well documented elsewhere. You can signpost them, but actually, what are the outcomes that you're trying to bring about as an ICB?
It reminds me of the old adage, sorry I wrote you a long report, I didn't have time to write you a short one. I think one of the things that I was trying to set out at the very start of my intro on this is that with the reworking of the terms of reference and new members of the new ICB versions of the committees, you can't scrutinise something unless it's a trajectory written down that explains how. Because anyone can just say, here's year to date, there's the number we should get to, end of story. That's not a plan. That's a Christmas wish list. So where we're moving to which is why when we get to the new recommendations that are in the latest paper, which I've got on my screen, which I'll read out in case you haven't got it to hand, I actually do recognise that there are key areas where we still have made huge progress on year to date, summarising one version of the truth and that kind of thing. I agree, Rachel, it's still, out of 300 pages, probably 299 too many in my book, but we still need to be more concise as to where, if you think about it from a committee's perspective, we've got to get, and this came out of our survey, collaboration and partnership is great, but if the metrics and the data we're talking on and the how we're going to get to where we want to go, if we can't measure that, then we can't be sure we're actually making change. We can anecdotally say it, but we can't evidence it. So increasingly, the piece of work that now needs to be done is, and thank you to the team that have actually pulled together the year-to-date work and trying to get this into a state. When we had our away day and you presented it in the team, I mean, you could see the genuine fantastic shift that we've made on this, but it still isn't giving on the key areas enough of the how over the trajectory that our committees can actually scrutinise. So that's the next phase that we're going to be going through. And myself and the committee chairs have spoken, and we are going to be committing ourselves as chairs of our variety of areas, to ask yourselves the question through your committees, and you're meeting, let's say 3 hours once a month, you have to ask the right questions at the right time. And those are the big heavy lifting ones, not the 1,000 KPIs at the bottom kind of thing. So you're going to be asked to formally write back to us and actually say whether you've got assurance on the plans that are in place looking forward. So what I would say is it's fantastic work year to date. Rachel, I'm particularly taken by your observation about the narrative, because narrative and explaining how we got here is lovely if it helps inform the things of actually looking forward. And because this is always going to be on the 2-monthly rotation in-year discussion, we now need to start using this performance data each month to be able to go, so how have we done against that? Now, we can't have huge level of heavy lifting done in this meeting because we've only got a short window of time, but we will be looking to those committees, which we'll be talking about in terms of reference as the month goes on, making sure that our committees are scrutinising the plans looking forward as much, if not more than, how did we get here? Sanj, did you want to add something?
Yeah, second what you're saying, John. I think a few additional points, just that I think we see in this report a concerted attempt around actions needing to be taken to improve the trajectory. But I think what we realised and discussed a little bit on a site visit to RCHT was also the sort of strategic actions, because if you look at some of the metrics, they bounce up and down if it's around flow or other things. And we're kind of victims of circumstance. And what are the key things over months, even year, to permanently shift some of these metrics? And at the moment, a lot of the assurances in the report are really around the same actions, and yet the number still keeps going up and down, sometimes very good and sometimes way off. And so what in that it needs to turn into a consistent shift, even over a longer period of change, to that trajectory you're talking about. And I think it would be good for exec to be assured that we do want to give space for that. It can't be done overnight. So rather than work to improve the number next month, we're trying to improve the number over a year. So I'd really want to make that point. And I think the other point about this is we really need to discipline ourselves around how much is in that main report, to Rachel's point, and have a lot of the supplementary information around the appendices. So what I've committed to do is to sit with certainly Kate and Simon in between FPCCs to go through that report, to really sort of literally cross out slides that can go in the appendix and focus around the ICB priorities in the main report, so that that's also where this board's attention is going to be focused. And if you want supplementary information, go to the appendices.
Thank you. Steve?
Well, two things. Firstly, to echo what Sanj has just said, I think that captures it really well. And to connect back to a comment Kate made earlier on about frailty transformations, there are a number of interventions which could have a material impact on the performance indicators that Sanj is talking to. So I think that's really helpful. The second thing I was going to mention isn't related to that, John. It was just to note Chris's earlier comment about excess mortality. I don't believe that's referenced in the report set that we have in the public meeting. There is a report for the later session, but just recognising that we're meeting in public, to check with Chris whether that's something that will be reported to a future ICB board meeting, and if not, is there anything more that we should say in the public part of this meeting?
So I think the mortality and morbidity group recognise that really, there's no reason why any of that data shouldn't be public, because I think it's really important. It's public data, so that it is for all of us to see. So I think the emphasis is it should always be in the public domain.
Steve, we brought a paper to board about 3 or 4 months ago that outlined all of that. So if any of you have forgotten, happy to redistribute that paper. But we brought it to public.
I appreciate
yeah,
it's not
and
a case
with Rachel.
It's not a case of having forgotten, Susan. It's just recognising that Chris has provided a summary, and there isn't a reference to it in the paper set that's here. And I'd certainly strongly agree with Chris's approach that wherever possible, these things should be in the public domain.
Okay, so as we start to finish this part, I just want to reference this again, because this is a new suite of agendas and approach to these sorts of things. If I use Tarn as an example on the workforce one, and Patrick, there's an example where it's not a question of NHS versus the system. We have to do both. And there are times when we'll want to deep dive into the NHS bits, and it's easier to have a smaller group really focus and deep diving on it. And there's a time to ask the broader question about workforce and system. And I think what we've got to do, and that's what the terms of reference are starting to think about, how do we frame membership and time to be able to scrutinise that? Because too often, again, what we're all agreeing that's coming out in the survey, there are times when we're all committed to doing this, but we don't seem on occasions to actually prioritise our time to be able to focus on the top priorities to actually shift it. And I think that's what our committees now have to focus on, that actually give assurance to this board that as partners, whether it be in the NHS or then on a wider system, we're all clear on the mitigations and the risks that we face for both in year and for the future. Did you want to add?
Yeah, and then Emma does. Do you want to do it?
No, you go first.
So first I want to thank Kate, because getting this out of everybody is like wrestling a crocodile, and pulling it together into a format where one section speaks to another. So it gives a narrative as well as the numeric view of Cornwall and the Elderslie. I think it's a great document, and it allows us to have an informed discussion, going back to Rachel's point, that it's great to tell us what it means. I think showing the workings out is important. So I would always like us to have the link back to the core data, and it's Steve's point really around where our baselines are. So the work that's in here will form the baseline for the committees, and then we'll pull it up to a so what. But our people across Cornwall and the Elderslie might want to see the workings out, so we need to make sure that they're available. I think the last thing I wanted to say was so in the quality report there is a section on mortality, but what it hasn't got is the control number that Chris has talked about over the winter. So I think for some of our change projects, it would be great if we set the outcome that we're measuring it against, which is what you're talking around with mortality, and then we measure ourselves against whether our officers and those are the people we work with are making a difference to the people that we serve. So I think for each of our projects, it's that baseline that we're working against. So I just wanted to say that, but thank you, Kate. You've got us a long way.
Yeah, I agree. Emma.
This kind of work is an art, it's not a science. It really is, and we'll refine that, I think, over time, so that we've got that very high level summary that really speaks to what the board's priorities are. I would just make a plea. I absolutely agree that the voluntary sector workforce needs to be in there at some point over time, but that needs to be in a proportionate way, which means that we're not spending an awful lot of our capacity feeding reports. So just to pop that out there. There's something, again, and I know there's a placeholder in there, but it's something that is going to be a big piece of work for us around the experience of the people that we're here to support. So, you know, again, making sure that we don't lose sight of that as a really key piece of work that, again, it's going to take time, but we need to keep that front and centre in the work and developments that we're doing. When you want to come in, Kate.
Just had a brilliant thought from, well, I think it's brilliant anyway, George. So, you know, if we had something around live experience from 1 month to the next, because there were lots of different places that we can pull it from. For Hazel and for Jane, in terms of are we listening to people and their experience of care during the process, it would be great to have something in here, Susan, through the quality section that talks about, we might have made you better, but how did it feel while it was happening, so that we can link into that in a structured way.
And I think that needs to be beyond friends and family, because that's about does the system feel like, and I think that's
My one challenge, Kate, on that, just before we move on, we have to be careful that we don't choose the anecdote that we would like to go into the report. There's something about evidencing this now increasingly. So it needs to be structured in its reply.
I feel like that's a piece of work in its own right, you know, consistent patient experience, well, not even patient, but people's experience across all of the services that we deliver. And then I guess that the speaking to the point then again, as we develop, that this becomes contextual. So actually we've got an understanding of how things triangulate together and how the finance, productivity and experience works, to think about reporting eventually against the triple aim. So.
Last word, Rachel.
Thank you. It was just, no one else had covered it except to sort of say that the general practice data, or it says primary care here, and I think that's in development, but in terms of general practice, the QOF metrics of previously, and if people have been in primary care trusts and CCGs, it was something that was of interest, and the performance around identifying hypertension or management of diabetes, really key things for the whole system. I just wondered if there's going to be that sort of focus within the primary care section of the report.
So yes, we can play that in, but we've asked Deloitte to identify 5 high impact pathways for next year. So I'd suggest we'd put those in with the QOF measurements against it. And I think there is something for our population. I didn't know till Rachel made me go to a primary care meeting nationally as a regional rep. We've got really good primary care in Cornwall. So evidencing that through our reports, I think is really, really important, because I think we take it for granted.
Okay, thank you. So let's move on to the recommendations, if I may. Now, just in case you've got the old report in front of you, I'm going to read out, because I think it's really important so that we're clear on what we're asking for as we go forward. So the recommendations in the latest pack are threefold. The first one says to acknowledge the integrated performance report, that it shows strong progress regarding reporting year to date and the format for reporting, but remains incomplete regarding performance issues across operational performance, quality, health and inequalities, workforce and finance issues. What that's trying to say, colleagues, is great year to date work, but now we've got to start to look forward. Are you happy with that recommendation? Yeah? Thank you. So report that. Second one is to agree that in order to provide satisfactory assurance to the committee's trajectories for all areas, particularly focused on the 5+3 top priorities, we need that forward-looking plans and trajectories by our December board meeting, 8 weeks effectively from now. And that's the rotation that we're going through for in-year, following the sign-off by the ICB, Finance Committee and the Commissioning Committees. Are you content with that? That's a big one that we all then got to sign up to, because what it means is that we have to commit to the December of actually having the how with enough granularity to satisfy our committees that they are mitigating risks of failure in year. And the third one, therefore, it all leads to agreement that on the December ICB board meeting that the new integrated performance reports commentary, i.e. the narrative, will look to focus more on the forward view and summary expectations of the how the trajectories will be met. So it's less about looking back, more about looking forward, and more about looking forward with the how and by when. That's what we're signing up to here. Everybody happy with that? Andy?
From a partner member point of view, very happy to sign up to that. I would just want Kate and the executive team to nod and smile at me and say that they believe that that's achievable. Thank you.
You've got both a nod and a smile for those who couldn't see it. Okay, thank you very much. Okay, everyone, so that's the integrated performance report.
Yes. Just following up from Andy's comment, I support all 3 recommendations. The ambulance handover trajectory is under extraordinary pressure currently in Cornwall, and actually that's the case across a number of other systems. And I think I would need to note the very significant risk of not being able to comply with the 40-minute ambulance handover trajectory. I don't think that would be a surprise to any of us. But in recognising and supporting and agreeing that recommendation, I think that there is a particular risk, and probably of all of the trajectory achievements that we are required to achieve, that might be the single greatest risk the system faces.
Yeah. So Steve, you've heard me say this a number of times, but just everyone says it. We are all in this together, and there is no point trying to set a task to catch someone out. No value in that at all. So there's something about asking the question, in a trajectory, do we all believe that it's achievable? Now, if it's not achievable, we need to be honest with each other, but we need to ask ourselves a supplementary question. But what would it take to make it achievable? Yes. And it's that supplementary question is, well, what would it take to get there that we want the scrutiny committees to scrutinise, to not just say, thank you, we'll defend why it can't be done. We want to unpack in all our committees going forward. Now, hang on, it's not being where we would like. None of us are proud of where that position is at the moment. So how do we get to where we'd be proud of most? How do we sign up to a new one that we all collectively own? And that, for me, is the absolute imperative as we go through the day. Are we all owning what we come up with when we come to our December board meeting, which will be the preface into winter? Are you happy with that?
Yeah, very, very happy.
Okay.
And an indicator that tells us what's going on in those ambulance holds is excess mortality. So we have it within our gift, isn't it? Collectively. So I'm not looking at SWAST or RCHT, but collectively it's in our gift to reduce excess mortality over winter by the choices we make in the next few weeks for our system to flow. And I think it was you, Steve, when you were saying around frailty, put the point in the SPC chart, because we should expect to start to see things changing. And if they're not, it needs re-ratcheting. And by the time we get to December, I want us to bring change that shows SWAS can deliver their targets because that's good for our people. The front door's free because that's good for our people. And we've got elderly people in the right part of our system because it's good for our people. So that is really what I'd like for December.
And one of the things, again, please excuse me for saying this because it is a bit new to all of us. There's no point coming back in December with a plan that says we'll do this in March, right? So the idea is we've collectively agreed to this and we're sharing with the board the how, and it would be lovely for you all to sort of say, and by the way, we started this 7 weeks ago, all right? But that's managing our collective expectations. So long as you're buying into this, then really collectively, we all have a duty then to say, what will it take to get us there? And I Steve, and I meant to say, as Sanj raised it, we had an excellent visit to our CHT, and there were non-execs and executives from CFT, RCHT, and the ICB. It was an excellent visit, if I may say. We had an open and transparent, and I thought it was an excellent conversation across everyone. And it really, again, felt partnership, collaborative. Now we've got to focus on the things together, and what will it take? And that's what we're about to start to move into, if that's all right with everyone. So I think that's been a pretty good debate. Thank you. Thank you, Kate, again, for all your hard work on that. And hopefully you've got the signal now that the bit that you've been missing, everyone's signing up to give us to. Okay, thank you very much. So let's move on. Actually, do I need to? Oh, I've done the recommendations, so we're happy with all those three. Okay, so updates from we'll go around the committee chair. So I'll go first of all to Tan. Is there any update from yourself, Tan?
No, not specifically. That's not in my report. Thanks, John.
Thank you. I'm just checking is Neil, Neil, are you on the call? Are you still there? No, Neil is dealing with some home issues, so I understand that. Martin.
Just what's written, I'd say, John, so good meeting and starting to work in the new format as the audit committee as well as the other committees that you've mentioned.
Very good. Thank you very much. Sanj?
Yeah, part one was mainly around the IPR, which we've largely covered. I think the focus is to work on those improvements that we've identified for the next iteration. So it's constantly improving the quality of the integrated performance report, which you'll see next month.
Let's move on to partner updates. So I'll just go around the table in the order in which I can see people. So Debbie, from your seat, please.
Yes, so I've got nothing to add to the report that's in the pack, John. Excuse me, I'm losing my voice. I had vaccinations yesterday. So but I would like to report to the board nationally. There's been approval for the 2 learning disability and autism inpatient units for the Southwest. And I think that's just excellent news. And that really has been joint working across all the integrated care boards in the Southwest region. And I know Rachel's here, but the support from region's been phenomenal. So Jill and colleagues at region. So I know we've had support from Elizabeth Omani to ensure that the needs of those with learning disabilities and autism stay front and centre despite all the challenges. But the other exciting thing is that we're going to have 2 projects, one in the north of the patch close to Bristol, one in Devon. There's been a clinical model that's been co-designed with people who use services and their carers, and it will not be like a traditional ward environment, the like of which we've seen before. So it's really being designed with the lived experience of those who actually have not been served well by admission to traditional services. Now, there is no intention to increase the number of inpatients. The intention is to ensure that we have better facilities that serve only the very few that require detention under the Mental Health Act. But it does mean that we will be able to, as a Southwest region, bring people and provide future care for people much closer to their homes, locate the expertise where it's needed, but at the same time continue to work in local systems and places on keeping people out of hospital in the first place. And that bit's the crucial bit. So I'm sorry I've added a slightly lengthy update, Chair, important. But it's really important to say this is not a return to building inpatient wards for people with a learning disability. This is about improving the overall service offer at the very top of specialist care.
And that's really exciting because you can't come home if there isn't a plan for if there's a crisis. So it's amazing. There was a really, really good presentation at the Health Overview and Scrutiny Committee yesterday from Rachel Rotherow and Louise Wood around supported housing, extra care housing, and the needs assessment they've done around what we need across Cornwall and the Isles of Scilly. You know, like we did for forensic psychiatry, that if you had a community team and an inpatient this, and you had a low secure unit and a medium secure unit, you only needed one high secure bed. I think we could do the same for learning disabilities, because we've now got the full chain of things being planned. So I do wonder whether we could do an end-to-end, if we pull to get everything together, people living in their own home and crisis extra support. It would mean that we could plan a much better system for people with ongoing care and treatment needs. So Rachel, would you pick that up in terms of introducing, I don't know whether you're the right person to pick it up, but introducing the work to Debbie so that we can then plan for our population across a continuum?
Okay.
We also know that for really specialist community, so supported living, and that different mix of home care resources, micro commissioning. We know that there's work that we can do across Devon and Cornwall as well, so that we can attract some of those more experienced community providers. So it would be really helpful.
Thank you. Okay, let's move on. Andy?
Thank you, Chair. Report has read. Just 2 points that I'll draw out. Obviously, general practice remains busy on our GPAS data. I'm hoping at a future board, if it's welcome, to probably highlight some activity from COVID and influenza vaccination clinics. I haven't got the detailed data, but certainly on my own patch, I've got one practice that delivered over 1,000 patient jabs on Saturday, last Saturday, and 1,000 on the previous Saturday from 9 registered clinicians. So there is an enormous activity going on there. The second highlight is that yesterday we opened our first integrated health and care hub run by East Cornwall Primary Care Network, spending the Section 256 money. So I want to express my thanks to Rachel and her team for getting that over the line. Really exciting opening. Thank you.
Ask you a question, because when the legislation was written, you've got a pretty wide portfolio. Is it fair to say it does cover areas in terms of not just sort of GP, but all medical services? So it'll include pharmacy, optometry, dentistry. I think the answer is yes.
So the answer is clearly yes, Chair. So we'll do that at my next performance review, that I am quite clear my primary care department member covers my colleagues in pharmacy, dentistry and optometry. And for the purposes of my first comment, recognising that our community pharmacists are delivering some of that workload.
So where I was trying to go, I wasn't trying to be cheap, I apologise if you felt came across, all right, is I should have said also, we have a fourth person representing the GP collaborative, which is representing, he's not the chair, but Stuart Smith is the nominee that's been put forward by the rolling chairs of the GP collaborative. So Stuart will be one of the attendees, along with Nick and John and Eva and Jenna. So there's something part of me that thinks that if you could coordinate with your other 4 colleagues, it would be, rather than have everybody write more board reports, just have these key headings of pharmacy, GP practice, kind of thing, and it gives us in the round. Then I think from your seat, some groups of people who are much closer and have the bandwidth to contribute. Is that right with you, Nick, for example?
Yeah, very, very happy to connect.
Does that work for you, Andy?
Yeah, perfect.
Well, thank you very much.
Okay, thank you, Steve.
2 things. One, I'll draw up from the report. One, some additional context, and the thing that draw up from the report is the work on the Isles of Scilly. You'll see in the report the work that CFT have been doing to deliver virtual wards to reduce the need for travel for patients from the Isles of Scilly. And there are a whole range of additional challenges clearly for patients and communities on the Isles of Scilly. So really positive to see that progressing. The second matter is and I touched on it before, is the operational pressures across our system and actually across the wider peninsula. You'll see reference to the pressure that SWAST have been operating under. That's continued. And actually, since the industrial action at the start of October, many hospitals in the southwest region have been under sustained and continued operational pressure. OCHT in Cornwall now is Cecily operating an Opal 4 UHP and Devon colleagues. Similarly, there's been a lot of understandable media coverage and community questions around that, and all providers continue to do everything they possibly can in partnership with our wider system colleagues on reducing that pressure. However, it does continue currently, and trusts at Plymouth at Royal Cornwall Hospitals continue to be unfortunately holding ambulances as we continue to take the actions that we can to reduce that.
Thank you. Just before we move on, the thing I'd like to just tease out a little bit here is now with Kelvin being part of the group, and with your wider hat on, Steve, there's some part of me that wants to ask the question in terms of I'm going to use it sort of the digital touch points that people are using here, which is less about the infrastructure of EPR behind the systems, whatever, and more about how people work with us. And that can be a telephony touch point, it can be a digital touch point. I think. Could I ask maybe if via yourself, Steve, working with Kelvin, if on another day when we come back to our strategic board meeting, maybe we can have that conversation around what is going to be transformational the long term, but not for now because the tram lines are up and I need to stick to it too. But if I can ask the question for next month, are you happy with that?
Very happy to.
Thank you so much. Okay, Rachel, is there anything you'd like to update on behalf of Ali?
There is, if I can find my report quickly.
Want me to come back to you?
Okay, no, I'm here. Brilliant, thank you. So on behalf of Ali, and I know that, apologies, there wasn't a written report in the pack as there usually is, but I think in summary, on behalf of adult social care in this part, the recovery following the pandemic is progressing, and there's an improvement in the number of people waiting to have assessments in adult social care. But still, as of the 2nd of October, there are 695 people who are awaiting needs assessment, 343 of which have been waiting less than 28 days. And clearly those that are highest need are in receipt of short-term plan pending that assessment. So there is a triage process of that, but that's still clearly a challenge, but it is an improving picture. 5,263 residents have received a review of their care and support plan in the last 12 months. So that's giving a scale of the activity in that area. 1,471 people are awaiting a review, but that is down from 2,677 last August. So a significant reduced amount of people awaiting that review of their care. So so a more positive picture on some of those high level figures. There are 139 people requiring a package of care to continuing living independently at home or step down provision, and that is also, although a large number, a significant improvement since last year. So they're the high level you usually receive in the report, so that's why I wanted to read them out. Obviously as well, there is a thanks to partners who have been involved in the LGA peer review challenge, which is an new inspection regime that will come in and be CQC assessment for adult social care in the council and the ICS, but this was a peer review to inform areas of development. So thank you for anyone who's inputted into that this week. And then finally, I think there's been a whole range of staff conferences across adult care and wellbeing over the last couple of weeks. I think it was 4 fully attended conferences and a lot of engagement and learning from staff around improvement and a range of topics. I'm sure Ali can feed in at the next partner update. And then I had already mentioned the tobacco control element, which is one I wanted to raise under my report, so I'll leave that there. Thank you.
Great, thank you. Nick.
Briefly say thanks to Rachel as well, because I know that in Cornwall, community pharmacies now have no upper age limit for the morning after pill, which is one of the first things that have been done as a system. You've taken that step, which is again quite unique. I know it's been nationally recognised, both from national media and certainly pharmacy media. I did an interview yesterday. I know Rachel was quoted on the BBC. So I think that that's something that just to recognise as a joined up system approach of accessing care in an appropriate thing to remove the 25 years as a upper age limit to receive the morning after pill or emergency contraception, however you want to call it. And I know that Rachel's been supportive in getting that through, so I wanted to recognise that as a partner. Thank you.
So Rachel, so Steve, Chris, Carolyn and I were at the Overview and Scrutiny Committee yesterday, And I just wanted everybody to know that the medium-term financial plan for the council budget is out for public consultation. So I didn't know whether partners around the table would be aware. We're also developing our 5-year medium-term financial plan. So I did offer at the Overview and Scrutiny Committee if we could get Section 151 officers together, in our language, CFOs. So we make sure that none of our assumptions are tripping each other up, because we might find our holes are larger or smaller than we thought they were once we've had a conversation. So, and the Overview and Scrutiny Committee were happy with that suggestion.
Okay, thank you. So there are other, I'm a bit conscious of time now. Would anybody else like to add any updates on their reports? Emma?
Very briefly, I haven't done a report paper today, but I just wanted to update you on some of the pressures around the Community Gateway, which is an ICB funded service, which is absolutely fabulous. They're taking just under 3,000 calls a month at the moment through the Community Gateway, and producing 520 personalised care and support plans, which is absolutely fabulous in terms of the delivery. Where we are starting to have concerns is around the level of complexity and crisis, and we're already progressing conversations with some of Debbie's team. But one day last week, a caller had, or one of the staff members had 3 suicide ideation calls in a row. So I just wanted to let board know that the kind of complexity and levels of crisis that we're starting to see in calls to the gateway is something that we want to make sure that we address. So we're already talking to some of Debbie's colleagues, but I just wanted people to be aware that that's something that we do need to work together on.
Yeah, so if we're not already working together on it, we should, but we also have a number of different support offers for some individuals. And so, of course, you wouldn't expect me to comment on an individual case, but there is the 24/7 Mental Health Connect line, which we always promote. But if someone is known to services, then there should be an immediate crisis response. And if there isn't, then there should be an assessment response. So I think we just need to get the pathways.
Yeah,
we just need to get the pathways right.
So I'm reminded of when I was a part-time statutory community psychiatric nurse, part-time centre nurse in a third sector project. Until I shared the role, I wasn't allowed to refer anybody anywhere. When I did share the role, I was allowed to, because I became a proper person again. So I think there is just something here around how we can pull the edges, because lots of desperate people will go into the most accessible place, and sometimes it's not us. And then my other point, so Emma and I spoke around the welfare rights. No, it's not for the welfare rights. The Citizens Advice Bureau that's got financial pressures in you. If ever there was a time to not allow an agency that provides structured advice and support to people around where they live, how they live, and can they pay their bills, now's the wrong one. So Emma's spoken to Rachel, and we will use some of our Section 256 monies to support keeping the Citizens Advice Bureau going. So Rachel, thank you for that, because I think in terms of a system working together, it's a fab thing to do for our people.
Okay. Right, shall we move on, colleagues, from the updates, unless I've missed anybody who'd like to say anything? No? Thank you, let's move on. So I'll just set the scene on item 10, and then Karen will go into the details. So again, let me just say again, there's something here about, this is the risk register that we have done before, but as we now go forward, we've got to start developing an in-year risk register and then a strategic risk register, and they will start coming back every month, and they will inform the agendas and the priorities of our board, as they should do, and they will start informing the agendas of our committees, as they should do. Carolyn.
Yeah, thank you, Chair. So that just sets it really nicely. Obviously, we agreed our principal risks in May at the board, and as we move forward to this different way of working, obviously we need to look at our risks, making sure that we're looking at the appropriate risks in the appropriate arenas. So the work that we've started to do is looking at our principal risks, looking at what kind of current risks are sitting alongside those, and effectively starting to look at where they would sit from the new committee perspective. We now need to look at, as John's alluded to, making sure that at this meeting in future we will be looking at any in-year risks, and obviously in November's we'd be looking at any strategic risks. So the piece of work that we've started to do is look at those risks, look at the committees that they may well sit into, and then looking at what we do to mitigate them and those kind of plans that we have for mitigation. So you'll see in the appendices, certainly around the first one where we're talking about risks of ambulance turnover and cancer targets, we're looking at mitigations to prevent the risk around the UEC recovery plan, the RTT recovery plan, etc. So this is a piece of work that we're doing at the moment. Clearly, it's an ongoing piece of work. It's just to bring it to the board's attention, but also to recognise that risks are dynamic, and obviously they're going to flex and change, and some of them will be very short-lived and some will run for a bit longer. But it's how we get and agree that risk scorecard for each of our boards as we now see them going forward. But also, as John alluded to earlier, we need the committees now to start doing more of that heavy lifting, and that some of that heavy lifting is around risk assurance and oversight. So that's really it, Chair. That's really what I wanted to say about this.
Yep. Kelvin.
Just wanted to highlight that obviously cybersecurity is a national issue. It's actually recommended that all organisations across all sectors manage that as part of their activities, or already do so in the provider organisations. And actually, nationally, the NHS focus on cyber is now being channelled through ICBs. So I'm going to propose that I'll work with Caroline in terms of recognising cyber risk for the board.
Thanks, Kelvin. That's helpful.
Okay.
Really helpful paper. I think it builds on, Carolyn, the previous discussions we've had. Just a couple of things. I'm very supportive of the principal risk entries being agreed by the ICB non-executive members and ICB executives responsible for the committees. We do have provider committee chairs and provider executive leads joining part of our discussion in the private board section this afternoon. So there may be some benefit as that progresses in those risks being tested, shared with our CFT and RCHT committee chairs and lead executives, not to change the approval process, but there may be some value in that. Just a quick recommendation 2 refers to the items being a standing agenda item. I think that's a standing agenda item.
Yeah, I did. I noticed that. We're not biased
thank
one
you.
way or another.
Then the final comment from me comes back to Chris's earlier comment about excess mortality and whether we're clear enough in our risks around that risk. Now, that could fit and be part of that first risk, but if it is, I think I'd be challenging us as to whether we're clear and explicit enough about it, or whether there would need to be a separate strategic risk to reflect that. And I think that's not necessarily something, John, we'd need to resolve today, but I'd be grateful if as our committee chairs consider that, we could give that some consideration.
One of the things, very happy with that, and I think as we're maturing, one of the things in terms of the honesty we're now sharing with each other, is one of the things that I think the committee chairs would vocalise is that if you look at some of the things that have gone to their committees, it's tended to actually come from the more junior groups, as what they think are the key things, and then it's been fed up into the committees. What we've got to increasingly do is to say these are the board risks, and then these become the committees kind of thing. So it's not saying that's not important, but maybe those are dealt in a different order of magnitude that need to be dealt with, while we've got to focus on our top priorities. So this was where we were, and I think all we wanted to say today was this is not where we're going to be, but we want to work that up in collaboration as we go through the next 8 weeks. Again, one will be in the year for December, and the first one will come, the strategic one, which will be the starter for 10 in November, and that'll be a different one, so we'll be rotating them. Rachel.
Yeah, thank you. And just accepting the comment that you just made, I suppose I'd also control environment is not having is having the plans, but it's the committees that deliver the plans. There's a lot of reference to plans, but also you have in place through the executive as well as the joint committees a system-wide oversight group and various other executive meetings. I'd want to see those documented, because that for me is where we potentially, and yourselves, need to hold the accountability as well.
Great comment, thank you.
Yeah.
Could I just respond back to Steve's?
Yeah.
So I've just had a little note from one of my learned friends to say that actually there was a meeting with Chris last week to actually get a draft mortality risk being worked up. So there you go, just to make.
Thank you.
I'm really conscious, Chair, that this is an open meeting, but in community pharmacy, not through anything done locally, but from a national contract point of view, community pharmacies are at risk. There is certainly some divestment of properties going and potential pharmacy closures coming. So I'm conscious to maybe learn from Caroline that these things are fluid and they are dynamic, but they could affect significant population groups. And just from your guidance at some point where that feeds in, because that's almost outside of your control, but is something you need to be aware of. So one of the things you now sit here, so that's fine, but as a more structured route, the reason why I teased earlier on about you writing that into Andy's report is we can then formalise that, and if it starts to raise up, it's our duty then to consider it as we come to it. Okay.
So one of the requirements for us restructuring is nothing to do with money. It's to do with the operating model and environment of the CCG moving into the Integrated Care Board. And the way CCGs were structured are different to the way NHS boards often run. So it was very common for people who were passionate about something to have direct board access, and that was how decisions were made. Whereas we now need to bring for the whole system the business processes where the executive are accountable for the delivery of the business of Cornwall and the Isles of Scilly, and that's the wider executive of Cornwall, that things come through our internal exec and the system executive group before they then go into our committees and the board. And for us, that's a shift from one way of working to another, and that's why some of our committee discussions are slightly more detailed than perhaps they will be in the future. But it is a work in progress, and it's part of our new target operating model.
And it's been one of the values of doing an annual review of our committees, which ones have worked, which ones need to change, and how and when. Let's move to the recommendation. Oh, sorry, Sanj.
Yeah, 2 comments, John. One is, I think, an overarching point that if you look at the sort of risks against the True North objectives, they're at a level that's a lot more strategic than the committee level risk priorities. So taking my committee, on the strategic list, you've got sort of, are we spending the money in the right way? Are we driving out inefficiencies to focus on prevention? That's not reflected in the risks that the committee, my committee, is looking at, which is much more granular in year around balancing the books. And I think that gap is something we do need to look to address and make space to do. The other point is that if you look at some of these big strategic risks, again, under Truth North, person at the centre, you've got a whole bunch of activities, UEC recovery plan, Deloitte's work, etc. I think we need to marry them more accurately against joint committees, which is in the other column, but it doesn't really give that granularity of who's overseeing the Deloitte action or the UEC piece or so I know there's work to be done in the next couple of ICB non-exec sessions to do that, but just flagging that there's work to do on a good start with this to...
On that very point, why don't you pick that up?
I was just going to mention that obviously this is there is work still needs to be done. There needs to be some more detailed conversations with you as chairs of the committees about where you see it and where the gaps are. So as you've alluded to, there's going to be a couple of meetings where we sit and actually go into that level of detail that says, really, is this what we think needs to be there? What else is going to mitigate that? And actually, is that really your responsibility or does that sit somewhere else?
Yeah. Okay. And one other thing, sorry, is just with things like person at the center, it's such a big thing is I think we need to also encapsulate how are we measuring that we are putting people at the center? Because looking at this, I wouldn't know. We can do the activities, the recovery plans, but how do we know people are feeling at the center? So I think that's another piece that we need to do. I think that leads back to one of Emma's challenges earlier on. So we're definitely going to pick that up. It's one of my personal goals as well, which thank you for raising that, Emma. Martin, you want to add something?
Yeah, I just want to say welcome the structure we're putting in place, not per the sort of document, but per the committees and the board, because I think we've done some good work on this, but it's always felt a bit off to one side. We've got to get it so it's dynamic and flowing through and updated and part of our governance proper, because it has always felt a little bit off to one side, I think.
It'd be helpful. Let's move into the recommendations here, because one of the things which I'd like for us all to be clear on, particularly with your sort of chairing the FM Finance and Performance Committee, is at the moment we try and do too much in some of our committees. We try and boil the ocean and you touch everything and might not conclude anything. So again, given the fact that you'll have a committee before the board, the committee before the board that has the in-year should be bringing the in-year risks to your committee. So you don't merge these things together. The meeting afterwards is your committee before the strategic board meeting, which means the main focus there is about in here. It's actually about the strategic things. So we are trying as a board and committees, I know you know this, but I'm just sharing it with everyone. We're trying to carve out time and therefore getting the executive group to focus on their papers that actually come to those committees, because it's not non-execs who write them, of course. They'll have to think now about what papers are coming there. Now, the first ones on strategic will be easy to do because we've got strategies. How many strategies can you have? You can't have too many. The question then will become is how you start to execute those strategies. And that's what will become from November a little bit more interesting for us as a group, is rather than saying, I wish we had this and it's long term, it's how are we really going to make that long term stuff happen? And then it'll start to ask questions. What do we need to decide in year that actually make year 2 and 3 possible? Because if we don't do this now, we can't do that strategic stuff in year 2, 3 and 4. And therefore, if we want to do it in year, we have to carve out even more space of efficiency or change to carve out space to make spend on areas that we want to do. But until we square the circle of in year, it's very difficult then to actually move on to strategic stuff, because as we're about to find out as the day goes on, if we don't sort in year, we've already lost next year.
Just add one final point. It's just, I think the bit maybe I've missed here is just making sure that everybody understands that while we're talking about the committees, actually the executive team here, we are the responsible owners as well for these risks. So it's making sure that the risks that sit in with our areas that we are cognizant of, we're picking up, and that we are making sure that we mitigate. And I think to go back to your point, Rachel, that you're right, these things do need to come to the SOM, but they'll be going to SEG, they'll be going to other places. So it's broader than, absolutely, it's broader than committers. So although I haven't articulated that in there, I do recognise that it is wider and it will be seen in wider
I think that's part of the control environment together with your committees, so you should document that, because the plans, as you say, are come under scrutiny, ownership, delivery in those groups.
Thank you.
You may want to think about how you minute, and you've made it already, I don't know, but the pathway that should always go from the executive group into the committees, it might be advantageous for you to actually minute.
That's our target operating model, so that people know what's within their control, and then the process for things going into and out of decision making.
Okay, so let's move to the recommendation. So I'm always happy to make a decision that means somebody else can do some work. So
we know.
So let's recognise that when we get to the third one, it's actually a little bit more onerous on some of our non-exec colleagues. So for those of you who haven't quite got this, let's go through them in some sort of stable order. So the first one, I'll paraphrase as moving on from the risk register that we saw in May to actually having this concept of in-year risk and strategic risk rotating to support here. I take it everyone's happy with that direction of travel. Yeah. The second one is once populated, these in-year strategic risks, they actually come through here on a structured basis and will populate the ICB scorecard and assurance framework. I think everyone, that's pretty tick in the box. So this next one is more aimed at, well, it's aimed at everybody because of the pathway that comes from the executive into the committees and into here. But this does just highlight non-exec colleagues. As the chairs, increasingly, we will be turning to you to give assurance that either we have these plans in place or to be transparent with all of us. I'm not saying you're not transparent, but to increasingly share with us, if you're not getting the assurance, you need to have the confidence under this recommendation to share it. This is public money. We're acting in the interest of our citizens. We need to encourage us to have openness and transparency across all our system. So if you're up for that, I would encourage everyone to support item recommendation 3. Everybody up for that? Lovely. Thank you very much, everyone. Good discussion on that as well. So thank you. So let's move on. So we're off that one. Now, we have 2 items that are ready for information. So by definition, for information, we don't really need 10 minutes to talk about it, but through just giving, go on. Go on, what did you want to say?
What I was going to say, if you don't mind, is the prevention concordat for the better mental health is there for information, but it is one of those items that will be coming as part of the strategic. So this is just there so people can have a little light reading ahead of the game.
Very good. I deferred to you. You'd articulate that better than I did. Did you want to say something, Rachel?
2 minutes just to introduce what that means?
Yes,
to
go for
people,
it.
just that item. So the mental health prevention concord, that's not doesn't trip off the tongue, but essentially it's a plan that is an all-age plan that sort of summarises a lot of work to date in one place. And outlines some of the intelligence, the sort of leadership approach around preventing and delaying mental health problems. Noting we've got a real challenge around suicide and the growing need for treatment. So this is all the upstream approach, and it's describing that, but also then asking for support from the boards. It previously was supported by the Health and Wellbeing Board, but it's a collection of work underneath that standard, which OHID, the Office for Health Improvement and Disparities, is asking all areas to put together. So we apparently are one of the first in the region to have got to this stage as a refreshed approach. So it's really that for you to review that content, because it is quite a lot in there for that discussion at the next meeting in a little bit more detail.
Lovely.
So just hope that simplifies what
Very good.
lots of
Thank
information
you.
is about.
It's for information. Yeah. Yep.
So you know when we're looking at it, because Donna, I can't remember her surname, which is the new Director of Children's Services for Plymouth City Council, and she's come to the southwest from Scotland. She is a breath of fresh air. And one of the things that she does talk about is the difference between mental health and protective factors for mental health and mental illness. And they are connected but different. So there is something around this prevention concordat. We should be thinking both, because self-esteem and decision-making starts from childhood, and it's a core defence for being mentally healthy. So I just would like us as a board to read this within that context, and that it's not all about mental illness.
Very good. Thank you.
I just concur with that, John. Absolutely, and I would say that we're quite a long way along supporting those core principles, Kate. So certainly through the Children's Partnership Board and other areas, there is that real focus on well-being and not stigmatising through labels. And so I think it's something that we should all be attending to. But it's a very helpful reminder. Thank you.
So we'll be coming back to that one as part of our longer term discussions. And the apology is on item 11, because we should have taken this when we had the Cornwall Health Watch annual accounts, annual report. But at the time, Nick didn't remember that he actually covered both health watches in his boardroom. So that's an apology from me, because we should have picked that up. So this was our submission to sort of submission. Apologies, and this is the annual report for the Isles of Scilly Health Watch. Noting the fact that there is still not a chief executive in place, as I understand it, for Health Watch yet.
Shall we write to Paul to thank him for the report?
I think we should.
Yeah.
Yeah. Thank you so much. And please send our apologies for last time. Okay, so that neatly brings us to the forward plan. So, just for a moment, those tram lines on my bowling alley have popped down. All right, we've got the opportunity now to look towards strategic and in-year. So we've had the discussion around some of the in-year stuff. What that will mean is if we jump past November, a lot of the things that have come out of this discussion will come back for in-year discussion in December. So you see how this is going to work? So we're going to go to December 1st. That might sound weird, but it follows on from the logic of this debate. Are there things that are missing in here that you think, other than the standing items, because there's mostly standing items at the moment, that you think that we should be having back here that we haven't talked about before? Do we want to have, for example, mortality, morbidity updates come back on here and make it more of a, we should do, I think, on here? Carolyn?
So in December's, it would be really helpful in the way that we formatted this to understand if colleagues have items from today that they want to bring forward into that meeting. So if there's anything that we've discussed today, it would be really helpful to be able to pull through. Now, there's some of those things may not come out of today or may come out of later, in which we would populate that. So I think, Chair, taking that conversation today, and then maybe if people are reflective, because there are some people who will reflect.
Sanj?
I appreciate it might be within the integrated performance review scorecard, but should we not have somewhere in here about the winter plan and
Yeah, that's a good call. Yeah,
how that's progressing?
definitely. Part one, winter plan. More quality debate on that. We'll be in the thick of it, and we should be prepped and ready for it.
Well, we should be delivering.
Yeah,
So that's one of the things
that's
we
what I
need to be really clear.
Rachel?
Just a suggestion, but I didn't know whether there was an opportunity to look at child health and children's services, maternity or children's services as a
In-year.
in-year.
And who will produce that report?
Susan. If it's children's or maternity, we've got the LNMS that we can bring. We'd agreed some time ago that we'd bring quarterly report through board from LNMS.
You're the lead exec for
But I'm the lead
children,
exec, so
Fine,
if we
so if
can
you
be
take that
specific
away
about what we want.
on that. Okay,
Should we chat?
so let's just reflect on the report that I've seen that you haven't yet, which is your feedback, which is we don't spend enough time drawing a line between the discussions, the forward plan, and then following them up enough. So I think if we can just look forward, and maybe when we're issuing this, bring forward the forward plan a bit more into people's psyche, that we can actually spend more of our time saying, right, at the end of this part one, we want X, and we're all, that's it, I've had my contribution, I'm really clear. This is what we must have by then, because these are the things that are going to shift the dial for us, is now focus, right? Okay, I think we've laboured the point there. So let's just move for a couple of minutes into the strategic world. Now, this was a starter for 10, which is a lot of standing items. So just, would you want to start with a refresher on the joint forward plan, the integrated care strategy, or do you want to drive straight into the medium-term financial plan as a focus? What I'm trying to get at is one might follow the other, but in some ways we've agreed our joint forward plan, which is the 5-year, we have agreed our 10-year plan. We're focused on the next couple of years. Where would you like to start?
So I was just reflecting on the conversation that was had with the visit last week, and actually I had to about roadmaps rather than detailed plans, but actually are the roadmaps on track, and how do the roadmaps link together? And maybe that's a conversation that more strategically, I think, just in terms of people's understanding and the interfaces.
I think it would be really helpful. I was so impressed, Steve, when Sanj and I and Neil came down, and the presentation of your here we are now to 2030. And the key bubbles, if I can put it that way, the key items that were going to happen each. If we start with those, we've got to start somewhere, everyone, because we've got the joint forward plan. It's sitting on a bit of a shelf. I'm sure it's more than that, but certainly will be driven by the medium-term financial plan.
So if it's not more than that, we should all stop meeting.
Yeah. All right. So there's something that is driving the medium-term financial plan that's written in there. So I'm just wondering, do you want to?
So the medium-term plan, so our 5-year forward view and our 10-year strategy are our structured promises to the people that we're serving that things will get better around here. Yeah. The medium-term financial plan is the first 5 years that gets us to a break even, but still having to achieve the triple aim that's been set out for ICBs. So I think we can do a roadmap for some of the outcomes that are in our 5-year forward view, not all of them. And I think some of the outcomes that are right in front of our noses in the first 2 years are possibly the most important. And we know falls, end of life and frailty are important things for this year. And next year, it'll probably be planned care, diagnostics and long-term conditions, because it will reshape the way care is provided in Cornwall, and I'm including mental health as a long-term condition and a planned care point, Debbie. So there is just, I think we need to play those bubbles through, because if we deliver years 1 and 2, then we can have some imaginative thinking around what years 3, 4 and 5 would look like.
Steve?
I support that. I think that's really helpful, and I think framing the start of the strategy focus in that context would then really set the scene for those other areas. And I'd be very happy, Kate, to work with you and Carolyn and colleagues in kind of helping to develop that kind of
So
summary.
could you take that away with colleagues, executive colleagues, taking an excellent steer from Rachel about how we might go about doing this, and recognising it's the start of the next phase. Very Churchillian, ending at the beginning of the end, whichever he said. Happy with that?
Yeah.
Lovely. So that's the end of the forward plan. Thank you very much. So let's move on. Are there moving on to questions from the public relating to the agenda. Are there any questions, anyone from the public that would like to ask on the agenda? I'm watching for hands up just in case. I'll give it a second. No? Okay, thank you. So I believe that is the close of the part 1 meeting. So thank you, everyone. Before we leave, I just want to say thank you for that. We are starting sharp at 12 o'clock. We have external people joining us as well. So please be back if you can for 12 o'clock. But thank you very much. Let's leave the meeting there. Thank you.